You've been busy. Dot is very engaged in her work and the community she's in. She sits on many committees such as the local and regional Elder Abuse Prevention Network, the Behavioral Support Services, Mental Health and Addictions, Complex Care Resolution Committee, and will soon be joining the BSSTU. She is also playing a role in designing the Behavioral Support Treatment Unit in the Southeast Lynn. Welcome, Dot. Yeah, I'm going to introduce everybody. Our next speaker is going to be Elizabeth Bryce from Leisure World St. George. Hello again. I recently visited there. Elizabeth, after receiving a Bachelor of Science, found herself with a continued eagerness to improve the quality of life and well-being of people, leading her to study social work and specialize in gerontology. Elizabeth graduated with honors and began to work at Leisure World Caregiving Centers St. George as an activation aide, moving quickly up to program manager, and in 2013 became the director of administration. Welcome, Elizabeth. Our next speaker will be Catherine Bennett from Bradford Valley Bloomington Colt Cedar Vale Lodge, right? Right. Catherine Bennett received her Bachelor of Science in Nursing from the University of Western Ontario and her NP-PHC certificate from York University. She currently provides nurse practitioner care to more than 400 residents in 3 long-term care homes in the Central Lynn, working with an interprofessional team at each of the homes to ensure residents receive timely access to care. Dementia care and palliative care are particular areas of interest to her, and increasing the in-home utilization of telemedicine to access specialist consults for residents has been a project of hers. Catherine also works with the Simcoe County Alzheimer's Society to facilitate an education support group for community caregivers and is a volunteer board member with the Georgina NP-led clinic. So welcome, Catherine. So I think with that, I'm going to turn it over to Dot. And hopefully we'll have a screen up here soon.
It's looking more promising. That's it. That's promising. Okay. Good morning, everybody. My name is Dot, and I'm here to share a little bit about Rosebridge Manor. Rosebridge is a home located in Ontario, of course, just south of Smith Falls, and we're very proud to be one of Omni Healthcare's homes. We'll quickly through some of these slides because I'm a little verbose, and I'll just quickly go through them, and then they'll be posted on the website so that you can access them there. We're a 78-bed long-term care home located, as I said, near the village of Jasper, south of Smith Falls. We're a C home, and as such, we have many physical plant challenges, such as placing a new resident with behaviors in a 4-bed basic room. That's a real challenge for us. Our how do I go back, I wonder? Our demography, I'll go through here. We have an age range of 56 to 101 years of age. Right now we have 22 males and 56 females. In 2013, our admissions were 47 and our transfers were 68. So obviously we have a lot of interim admissions due to our country location. We have a lot of mental illness diagnoses. I won't go into all of them, but they are listed. 85% of our residents have mental health diagnosis or behavioral issues. That's the statistics for just 2013. We've had 19 CISs in 2013, which is surprising. I would have thought we would have had a lot more. And calls to the police, 22. Our 2013 Quality Risk Summary Report showed that the quality indicator of behavioral symptoms affecting others was documented as 16.16%, well above the average of 9.9%. Okay. The ministry closed a lot of the psychogeriatric beds in Brockville Mental Health Center, which is in our catchment area, and they're now actively closing psychogeriatric beds at Providence Continuing Care. This results in a decrease in inpatient beds when we're in crisis. It's a real challenge to manage these escalating behaviors when we're unable to isolate the resident in the space-deprived home. There. Oh, did it again. I'm getting good at that. I talked a little bit of that quick slide about CCAC. We have some issues with our Southeast Community Care Access Center. We do have a good working relationship, and we try to be part of the solution rather than part of the problem. We get a lot of faxes with our medical referrals, and these faxes are faxed rather than mailed because we have so many interim beds and a revolving door for admissions. They don't get involved in financial affairs anymore in our area. I'm not sure whether that's all the homes or all the CCACs or not. But it causes a problem for us because we get them in, and sometimes within hours, sometimes within days, we quickly identify that there has been financial abuse, and it's really hard to get on top of it at that point. We have to do a capacity assessment because what CCAC does is they'll do an assessment just for treatment decisions, and we get them in the home, and then there's either not a power of attorney or there's a power of attorney that relinquishes it immediately as soon as they come into the home. So we're finding that that's quite an issue in the last couple of years, and we work a great deal with the public guardian and trustee, in particular in the Ottawa area. We deal a lot with BSO, and in the Southeast, in our area, we have a behavioral support team, and it's referred to as a mobile response team. All the ministry funding went to this model rather than offering the funding to the individual long-term care homes. It's been interesting, and rather than complain, I got involved right from the beginning with it. I've had a lot of thought about it, and I think perhaps I would have much rather had the funding go right to our home, because we've identified quite a few problems. Some of the funding is used for management, like the regional director, several managers, supervisor, coordinators, that sort of thing. And that money could have went to frontline staff in our home specializing in behavioral support. Their objective is to identify opportunities for improving BSO and conduct focused design dialogue needed to appropriately target the enhancement funding. We've had issues with the MRT staff being unable to staff us when we call for help, refusing to come in during an outbreak, and gosh, I don't know about you, but this year we're into our third one since January, so that's really difficult for us. Refusing to do one-to-one, and that's what I thought it was all about, and that's where we really need the help, especially with high-intensity needs. As you know, it's 72 hours, and then after that it's touch and go. There's no hands-on care, it's just observation. They come in and they've had some good training, but they're very timid when they come in, and our situation, where our home is very busy, and you have to due to a lack of options, individuals living with severe acquired brain injuries are often placed in our long-term care home. And it's sort of as a last resort because there's no other residential options available. Behaviors with acquired brain injury lack support in long-term care. It stops at the door. We're working on that. We're trying to get it to be an integrated service, but right now it's very difficult, and it's just like having, well, it is a dual diagnosis if they have psychiatric disorders and acquired brain injury. They're very difficult to manage. As all of you, I'm sure, we have psychogeriatric outreach. It's a great resource, but it's only available Monday to Friday, 9 to 5. And we're a 24-hour operation, and usually our issues are evenings, nights, and weekends. And they will not see the resident for the first 6 weeks after admission to allow them to settle in. And I understand that, but at the same time, that's when you have your worst behaviors quite often. They'll come from the hospital where they wanted to get them out of the hospital. They are saying their behaviors are stable. It's a snow and go situation. I'm sure you've all heard of that. They come to us and they wake up and they come out of their psychotropic drugs, and they're sitting in this new environment, and we see a lot of behaviors after that. So I'm a member of the Complex Care Resolution Committee for Older Adults with Responsive Behaviors. And again, I wanted to be part of the solution instead of complaining all the time. So I'm on this committee. And it's because there's a lot of complexity with the older population, as you know, the medical needs, the behaviors. But we accept these referrals with a lot of trepidation, and they say that our home in the Southeast probably handles more of these folks with behaviors than any of the other homes. But we still ask ourselves a lot of questions. Are we able to keep our residents safe? Are they requesting a 4-bedroom again? Are their behaviors well controlled? and what is the present behavioral climate within our existing residents. Because if we're having an escalation in behaviors of our existing residents and we bring another one into the mix, we can really get into a lot of trouble. So we have to consider those issues as well. So on this committee, what I've suggested as the only long-term care rep on it, how to get them ready for long-term care. Remove all restraints. I was shocked when I first started on this committee. They were still using 4-point restraints and vest posies in the one hospital. I won't mention which one, but and the staff were very reluctant to take the restraints off. They're very afraid of falls, etc. Condition the resident before transfer to a 4-bed room. I suggested they set one up in the hospital and have them live with 3 other people before coming to us, because so many of them are under PG&T, they don't have any money, they're going to be going into this basic room. I've asked them to tour the resident through the home. They hadn't been doing that, and we've suggested that they do that with a caseworker. Stay for a meal, stay for entertainment, try to make them realize that it's a home, not a hospital, that there is a difference. And we've asked for transition admission, and we did try that. We were the first home to try that. We had them stay overnight, then the next time they came for 2 to 3 days, and it really, really helped quite a bit with this one fellow we were taking into the home. They are now, we've asked for them to hold the bed for 30 days. The ministry was not too keen on that, but they've allowed that to happen. And so should the behaviors be unmanageable, we have a quick resolution. So we make sure we have the name of the person, the contact 24/7 at the hospital for those 30 days, so that our nurses remain confident that if they get into trouble, it's still there for them. Our critical incident reporting has increased dramatically for alleged abuse from aggressive residents in the past 2 to 3 years. And of course that leads to increased reporting to the OPP as well. I met with the superintendent of the OPP just in 2010, I think it was, when the new standards came out, and he had no idea at that point that it was so involved with calling and reporting the OPP all the abuse cases. So that was interesting. On a positive note, we have a lot of loyal long-term staff. They're very engaged in the home and its residents. There's been a lot of capacity building with our staff, such as PIECES, UFER, supportive measures, GPA, Montessori, and de-escalating behaviors is one we're doing now. Omni's fantastic with their education, and that is extremely helpful to us when we're going through all of this. I thought you might enjoy looking at a QI plan, a topic-specific one for resident aggression, what else? And I've just went through the change ideas, and I'm not going to read through them all, but you can see the different creative solutions we've tried to deal with. And then I just wrote down some of the special considerations in our home. We have limited PSW staff and resources to cover one-to-one, so that's hard when high intensity is 72 hours and then you battle with them for any extension. There's no appropriate quiet area to relocate an aggressive resident. Living in these 4 bedrooms, we wish we had a snoozling room or a quiet room. That would be lovely. QI plan. And, oh, there it is, came back. I'll be real quick. Anyway, I'll just let you read those. You can get access to them. But we had to analyze how well it was working. And there was a lot of things that affected the success. You can see untreated pain, UTIs, repressed sexual intimacy, shared accommodation, noise, fear, and so on. I saw this. I like reading Nelson Mandela's. He's very interesting, or he was a very interesting fellow. So this is something, I took it from his one statement and I changed one word, and I'll bet you can figure out which word it was. There can be no keener revelation of a society's soul than the way in which it treats its seniors. Isn't that so true? The word was, he said, it's children, of course, Nelson Mandela. So I changed it to seniors. This is my contact information. If anybody wants any contact or has any questions, they can contact me there. Thank you.